And we now move to Dr. Maciej Gawecki, who will speak about the use of micropulse laser in central serous chorioretinopathy. Please.
Hello, everybody. Today I would like to share my experiences with subthreshold micropulse laser in the treatment of central serous chorioretinopathy. We know quite a lot about this disease, however, its pathogenesis is not yet revealed. It's definitely more prevalent in males than in females, with proportion 3:1 approximately, and it occurs predominantly in young individuals about between 40 and 50 years of age. It belongs to the spectrum of pachychoroid disease, which is characterized by the increased choroidal thickness. Most of the cases spontaneously resolve, however, about 15% become chronic, and then they sustain a serious therapeutic and diagnostic problem. We also know that significant impairment of vision is reported in some cases, especially when they are long-lasting. CSTR can be complicated by the choroidal neovascularization, and since we use the OCTA, it is quite a large percentage. There are different studies that report different values, however, I believe that this is approximately about 15 to 20%. Nowadays, we tend to use modern diagnostic criteria which were published by the CSTR group in 2020. The major criteria are, of course, presence or past or present of subretinal fluid documented on OCT exam, but we also have to look at the alterations of the RPE, especially on fundus autofluorescence, as they are very important for the classification of the case. Minor diagnostic criteria include the hyperfluorescent areas on ICGA, leaks on fluorescein angiography, and, as I said, increased choroidal thickness. We use different types of classification of central serous chorioretinopathy. Traditionally, it was divided between acute and chronic cases with division point about between 4 and 6 months. However, as I said, multimodal imaging-based classification is probably better as it reflects the complexity of the disease. So we tend to divide cases into simple and complex depending on the areas of RPE alterations visible at fundus autofluorescence. Our Italian colleagues also distinguish between choroidal and RPE type. Choroidal type is characterized by very much increased choroidal thickness, even more than 450 micrometers, and RPE type by the attenuations of the signal from the RPE visible on SOCT exam. We use different therapeutic options in CSTR, not all of them confirmed in large clinical trials. So historically, we used to observe cases for 3 to 4 months waiting for spontaneous resolution. Classic laser photocoagulation was an important option, but for selected cases when the leakage point was located in the safe distance from the foveal centers. Nowadays, we tend to shift to subthreshold, non-damaging to the retina laser techniques like subthreshold micropulse lasers. Photodynamic therapy is a very valuable option, both in half-dose and half-fluence mode. However, we know that nowadays we experience shortage of Visudyne, so access to that modality is not easy in quite many countries. Anti-VEGF treatment is effective, but only in cases complicated by the MNV. When we look at the efficacy of subthreshold micropulse laser in clinical trials, the total resorption of subretinal fluid is reported in 40 to 80% of cases. On average, I would say 70%, so it's quite high percentage of cases that respond well to that laser. However, we have to remember that in long-standing cases, improvement of visual acuity is not to be expected. The average improvement reported is about 1 line on Snellen or ETDRS charts. I believe that the results are dependent on the case type, simple versus complex, as I refer to the multimodal-based classification. I also think that better functional results are with early application of SML treatment, and I would not recommend the delay in application of that safe laser. Here are examples of some large clinical trials with SML that prove the efficacy, especially morphological efficacy of this laser. When we speak about specific protocols, they can be used for both yellow and infrared laser. What's common is the duty cycle that empirically is set at 5%, and this is the safe value. Most commonly used spot diameter is between 160 and 200 micrometers, but we have to remember that it depends on fluence, so we can adjust energy of the laser to the dimension of to the diameter of the spot. When we speak about the treatment area, there are different approaches, starting from minimal treatment that targets just the leakage point, through the SOCT-based treatment, when we target the whole area of subretinal fluid visible on the SOCT scan. Panmacular treatment is also a very valuable option, especially for the complex, long-standing cases. Then we target the whole posterior pole within the vascular arcades. Transfoveal treatment is a little bit controversial. However, I think that both transfoveal and foveal sparing treatments work well. Laser power can be used in two modes, with fixed parameters or with titration, which is recommended by the SOLS Society. I think they also both work well. However, with fixed parameters, I would consider the lens status or IOL presence for the adjustment of power parameters. Here are a few scans of the OCT of successful SML treatment. We see on the right side the resolution of large amount of subretinal fluid with good, I think, retinal morphology at the end. However, on the left side, I think the case with significant retinal thinning despite resolution of the SRF. Here we see some more cases on the left-hand side, resolution of subretinal fluid with relatively good retinal morphology. However, on the right-hand side, impaired retinal morphology with significant retinal thinning. Ophthalmologists use different retreatment criteria for SML in CSCR. I believe that in case of unresponsiveness to laser after first session, we should perform the second one after 6 weeks. I wouldn't wait longer. However, I know that there are practitioners who use the 3 months interval, and both approaches, I believe, are correct. Timing of application of subthreshold micropulse laser in CSCR is a crucial issue. I believe that CSCR should be treated without delay in any case, also in acute cases. When we look at the scans that I present here, this is a case with total complete resolution of SRF. However, we see that retina is very much thinned, and we also see the areas of the signal void at the level of choriocapillaries on OCTA. That means that when the case becomes chronic, we can approach very serious alterations in retinal morphology, and I wouldn't allow that to happen. I would treat early, especially as we have in our disposal non-damaging to retina treatment modality. We performed a study where we analyzed the timing of initiation of treatment and final visual acuity. As you see here, there is a very strong correlation between better final visual acuity and early initiation of treatment in central serous chorioretinopathy. As I said before, PDT is a valuable treatment option in central serous chorioretinopathy. Resolution of subretinal fluid after applications of PDT is reported in 80 to 100% of cases. Also, improvement of BCVA is quite significant. These are a few lines on the Snellen or Logmar chart. The rate of recurrences is quite low, between 0 and 10% usually. However, when we compare PDT to SML, most of the studies do not report any significant difference. There is only one large place trial that favors PDT in that respect. Good results in application of PDT in CSCR are reported also in acute cases. At the end, I would like to propose a treatment algorithm for central serous chorioretinopathy. I believe that our approach should base on the evaluation of the CSCR type, especially referring to the modern CSCR classification. So we should distinguish between simple and complex cases. We should look also at the choroidal thickness and duration of symptoms. I believe that simple cases can be treated with subthreshold micropulse without delay. I think this should be the first line of treatment. I usually repeat subthreshold laser up to 3 times. If the response is poor, then I switch to other treatments, especially PDT. Long-standing and complex type of central serous should be treated without delay. I am trying subthreshold micropulse first, but if it doesn't work, I switch quite promptly to PDT treatment. I would also like to stress that both lasers, 577 nanometers and 810 nanometers, work very well. However, we have to use different parameters. Thank you very much for your attention.